Good, thank you, Jonathan. And again, to repeat what Jonathan and Brian have said, thanks to everyone for turning out. This is an important occasion for us, first to be able to send some messages to the community, but we're even more eager, I would say, to hear back from the community. So some of the later portions of this program are very, very important to us, and we look forward to your comments. Jonathan mentioned at the outset it's useful to first take an assessment of where we are. Let me mention very briefly a couple of points. St. John's is a community institution that is vital to the personal and economic health of Jackson Hole. St. John's care is not only convenient, but also vital, and excellent local care can literally mean the difference between life and death. While I'm not so much of a backcountry skier, I am aging, and I do ski and snowboard and rock climb, so I appreciate having an institution that may patch me together when I get a little over exuberant. St. John's is also a major
Get you a little closer to the mic.
yeah, a major economic institution, an engine for the valley. We're the largest employer in Teton County. We provide services for a substantial number of independent physicians and other healthcare staff, and we purchase an enormous variety of goods and services in the community. Fortunately, St. John's is now a robust institution. That hasn't always been the case. The times when Jonathan and others were heading up St. John's, the profits were sometimes non-existent. The cash balances were scraping zero, and there were real valid concerns about the continuing existence, or at least range of services that could be provided here. But I think we are now a robust institution, beginning with the fact that St. John's is a community institution. It's community controlled. Board decisions are made by Teton County citizens elected by Teton County voters. And this is very, very different from the model that's unfortunately becoming more prevalent. And Brian alluded to this. There is a lot of consolidation. Indeed, there are a lot of bankruptcies, closures of rural hospitals, or in many instances, rural hospitals simply becoming emergency department adjuncts to a major medical center hospital. The community now can count on a hospital with a strong administration, staff, and medical staff. Aided by increasing community recognition of the scope and quality of services, St. John's is generating solid operating profits. The board, the administration, has worked hard on broadening both the quality and scope of services, and it seems to be bearing fruit because of increased community recognition. We find less out-migration of full-time or part-time residents for elective procedures in other medical centers. As a consequence, we now have substantial cash reserves to protect against contingencies. And as Brian alluded to, and Lou and I will speak further to, there are a number of contingencies that we're mindful of. First of all, patient volumes fluctuate from year to year, and our workload is highly seasonal. In looking at patient volumes from 2013 to 2014, we saw in some important areas in the hospital declines from the range of 15 to 20%, with concomitant effects on revenues. This year, fortunately, we've seen some equally large upswings, mostly so far, and maybe thanks to a pretty rugged ski season, we've seen a substantial increase in a number of inpatient and outpatient surgeries. But as Brian mentioned, our healthcare system is heading toward bankruptcy. Part of the fix already underway is a reduction in reimbursements to providers, particularly hospitals. We're going to see more of that, doubtless. Regulatory requirements, some of which are productive, but they are certainly increasing and take increasing amounts of time and effort to deal with. We're also seeing moves of both federal and private insurers away from the traditional fee-for-service model and toward more bundled payments, as Brian mentioned. And these moves may be particularly problematic for small, somewhat isolated hospitals. We don't have the population base. We in Jackson Hole don't employ all of the medical staff. So these are creating particular difficulties for us. And community hospitals, lastly, are facing increasing competition. Brian mentioned 72 surgery centers surrounding one hospital, and I will speak more to this because these do create financial problems and pressures for consolidation. My particular focus today is going to be on the threat from profit-seeking ambulatory surgical centers and surgical hospitals. ASCs and surgical hospitals provide a limited range of surgical services to a selected subset of patients. The business model is very simple. Patients with a certain set of surgical requirements, typically not terribly sick patients, typically patients that are well insured, go into the ambulatory surgical centers for outpatient treatment and generate profits for their owners, which in a few instances may be community hospitals, but in many, many cases are independent private equity firms or major medical corporations and local physicians who can refer patients to the ambulatory surgical centers. The specialized surgical hospitals look almost identical. If you change the wording from outpatients in this slide, the ASC slide, the specialty surgical hospitals take inpatients. They can do more complicated surgeries like spine surgeries. But again, the model is the same. They're typically owned by profit-seeking private equity firms or major medical corporations, and again, local physicians that can refer patients to these facilities. I should note in passing, by focusing on a limited range of services and insured patients in particular, the ASCs and specialty hospitals can be highly profitable, which is why there are so many of them. The business model of the for-profit ASCs and surgical hospitals contrasts strikingly with the business model or community-oriented model of St. John's. We draw on a population that covers full-time residents, part-time residents, and visitors, all feeding into a broad range of services provided by St. John's. The revenues from those patients go to a disparate set of activities. And let me talk briefly through some of those. I should note also that while I've focused on patients here, St. John's also benefits from some other significant sources of funding, cash flows from the community. On a yearly basis, we do get some tax support, excise tax support. On an episodic basis, this community has supported St. John's very, very strongly in some of our major building programs. And finally, again, in connection with past building programs and in connection with a number of major investments in medical technology, philanthropic support coming through the St. John's Hospital Foundation has contributed to the overall flow of funds. But the funds themselves go to a wide range of activities ranging from some of the wellness programs that are called out in the bottom left hand, facilities maintenance, upgrading, expansion, medical technology, information systems, medical center collaborations. Lou and the administration have invested an enormous amount of time and effort in strengthening ties with major medical center hospitals such as the University of Utah or with Eastern Idaho Regional Medical Center in Idaho Falls. And we view these relationships as collaborative rather than competitive in many respects. They deal with patients in situations where we do not have the resources, the specialty skills to serve them. The St. John's flow of funds also facilitates physician recruitment and staff training. The recruitment may range from the hiring of hospitalists to provide call coverage nights and weekends that the independent physicians, primary care physicians may have trouble providing. We have recently recruited a specialist in non-invasive surgery, again, adding a service to the community that did not exist before. And lastly, and very importantly, the flow of funds, revenues from inpatient and outpatient surgery helps support a variety of services that are simply outright money losers or at best marginally profitable. And these range from the emergency department, the intensive care unit, the birthing center, the OB activities, and lastly, the living center. So this is a model radically different from the profit-seeking ASCs and specialty hospitals. The ASCs and specialty hospitals defend themselves, have traditionally defended themselves as efficient competition for legacy, translation, inefficient community full-service hospitals. And I'm not against competition. I began my professional career as a professor of finance at Harvard Business School, so I'm not opposed to competition. But if this is competition, it's not on a level playing field. When the owners of ASCs and specialty surgery centers focus on profitable services, they leave it to the full-service hospitals in a community to fund the vital but lower margin or loss-making activities that are vital to our community. Now, the capture of revenues and margins by profit-seeking facilities and the consequent diversion of revenues and margins from the full-service facilities tends to increase total community costs. The capital and labor costs associated with providing medical care to a community will ultimately be borne by the community unless there is a bankruptcy proceeding that wipes out some of the investment in the past. Redundant facilities and staffing add to the total burden in the form of direct charges or higher insurance premiums that ultimately have to be borne by the community. So in effect, margins going to physicians and other owners of for-profit facilities are not available to help support the loss-making activities of full-service community hospitals. The adverse consequences of competition are not theoretical. Wyoming Medical Center in Casper, for example, has recently been hit, well, recently starting in 2008, with a first for-profit making facility and just this year with a second. The consequences of the first for-profit hospital were estimated by the Wyoming Medical Center to be $60 million between 2008 and 2013. In part, this was a loss of roughly $6 million a year in sole community provider funds. The rest was simply a diversion of profit and revenues from inpatient and outpatient surgery. The same thing is about to happen to Memorial Hospital of Sweetwater County in Rock Springs. And examples abound. You go over the pass, Eastern Idaho Regional Medical Center is confronting the same kind of problem. So this is something that's a real concern to the board and the administration. For the reason that Wyoming has no law requiring that proponents of new facilities demonstrate a community need. And recent history, and this may be a sore spot for some with the refusal of the legislature to adopt Medicaid expansion, but the legislature, in my view, seems inadequately concerned with the preservation of community hospitals. So profit-making facilities are not required to apply for and receive a certificate of need. Indeed, a legislative proposal that would enable so-called ambulatory surgical centers where patients supposedly walk in and walk out the same day would enable the ambulatory surgical centers to perform inpatient procedures was only narrowly defeated in committee in this last legislative session, and I am quite sure that that will appear again. So in summary, St. John's is strong at present, but faces challenges that keep the board and the administration concerned and alert. Jackson Hole has a strong tradition of supporting St. John's. We may in the future need that community support more than ever before. Thanks very much.